All right, as people are joining, we're just waiting for Zoom to populate. We'll be getting going in just a minute or so. All right. Well, why don't we get started? So welcome to the CBITs webinar, which we are holding in collaboration with the Society for Digital Mental Health. I want to just, before we get started with our speaker, I want to just a couple of announcements. First of all, I want to let you know that we're recording this. And then I have one announcement about the Society for Digital Mental Health. It'll be holding its inaugural conference on June 13th to 14th. It'll be virtual, so remote, and 2 half days, so not a long time. So I encourage, it won't take too much time, but I encourage you to come. We'll be focusing on implementation and policy. And then in addition to the meeting, we're going to be putting together work groups to develop policy briefs and best practices guidelines to support rolling out digital mental health broadly in the United States healthcare system. So I'll put the link in the chat in a minute, but joining the Society for Digital Mental Health is free, and it'll give you updates as we go along. So with that said, it is a real pleasure to introduce Saskia Kelders, and I've known Saskia for a number of years. She is an associate professor of psychology and health technology in the Center for eHealth and Wellbeing at the University of Twente in Holland. So she is coming to us all the way from Holland, and later in the evening. So thank you for that. She brings together kind of, interesting expertise in both psychology as well as user-centered design. And she brings that together to study one of the most vexing problems in digital mental health, and that's engagement. So with that, I'll turn it over to you, Saskia.
Well, thanks, David. And I'm really happy to be here. So thanks for having me. And we really already know each other for quite a while, David, so really nice to be here in this setting. And what I would like to talk about today is some of my work, mostly from the past 5 years, but it's about engagement and personalization of digital mental health interventions, and with the question, can we overcome the one-size-fits-all approach? And if there's any questions, please ask them through the chat, and we'll see if we can get to them during the presentation or maybe afterwards. So first of all, what would I like to talk about today? First, a little bit of background into digital mental health, just to make sure we're all on the same page here. And next, I'd like to turn to technology and adherence, which is a little bit of my earlier work, but it gives also the background to why and how I got interested in engagement and personalization. And the last 2 aspects are exactly those. What is engagement? How can we measure it? And then on to personalization, and to see whether and how we might be able to use engagement for personalization. But let's just dive right in and go to the first aspect, so digital mental health. And I'm sure I don't really have to tell this in this setting, but when we talk about digital health, we often talk about supporting health and well-being by using technology. A lot of the times, or at least my research focus is a lot on information and communication technology. And when we talk about e-mental health or digital mental health, it's kind of just a focus on mental health instead of more of the lifestyle interventions, for example. And if we talk about those digital mental health interventions, what we've seen in the past years, I think the field has already been going on for quite a while. I think even a little bit more than 20 years probably. But what we've seen in digital mental health is that there are many web-based interventions. In more recent years, there's also been a lot of a surge into more apps, more smartphone apps, applications for mental health. But most of the research, or at least the older research, is still really much focused on web-based interventions. And what these web-based interventions have is often a fixed setup. So they're kind of using modules or lessons to get some psychoeducation across, and there are exercises so that patients or participants can practice with those, learn their lessons from it. And most of these interventions still use one form or a form of human counseling. Sometimes it's via video conferencing or typed feedback. Some of them are through chat, for example. But most of these web-based interventions kind of start from the same point with the same kind of features and content. And just to give an example of one of the interventions that I did some research on a while ago, this one's called Living to the Full. It's more a well-being intervention, or also based or targeted depression a little bit. And there you see there's a list of lessons that you go through in a chronological order. So first you go through week 1. When you finish that, you can go on to week 2, and so on. What you often see is that there are exercises in there. They're usually integrated within the psychoeducation. And in this case, you can also go there separately. And there's also a part of counseling. In this case, it's about feedback. And there were weekly feedback messages from a counselor that the participant could also respond to through email. So, and if we have these kind of interventions, so there's been a lot of research on these kind of interventions. And that's also, I think, a very good thing, because I really feel that we do need these kind of digital health interventions. Because at the moment, there are lots of people, of course, who are in need of mental health care. And we might not be able to give everybody the treatment that they need, especially not always in a face-to-face setting, just because of shortage of therapists, of course, always a cost aspect as well. But not everybody might be able to go to a therapist. So for all these kind of reasons, digital mental health interventions might be a very good solution. And I really think they can be, they are a promising solution. But I don't think we're really there yet within digital mental health interventions. There has been within the research community a lot of focus on outcome evaluation research. There have been many randomized controlled trials into these similar kinds of web-based interventions for different target groups. And on average, these interventions are very often effective. So that's great. But when you really look at this in a little bit more depth, we see that there are many large individual differences. So for some people, an intervention can be very effective, and for others, maybe only a little bit. And for another group, the same intervention might not be effective at all. And what I think that within research, we might need a little bit more of a focus on, we might need to learn a little bit more about, is why this is the case. So why do digital mental health interventions work for one individual, but not for another? So I really think that within the last years, or the last many years, because of the focus that is so much been on outcome evaluation, we've kind of forgotten or skipped a step that we really need to focus on why do these interventions work. And that's also because only if we know why an intervention might work for an individual, we might also be able to personalize interventions and be able to take a step further from this drawback at the moment that we have such large individual differences in effectiveness, and that we don't know how to match the individual to the right intervention. And to me, this was really kind of a starting point to think about, okay, I feel that this is needed, that we need to get this insight a little bit more, but how do we go from there? When I was looking a little bit more into process evaluation and the question onto what works for an individual, I found the model, the process evaluation model of the MRC quite helpful, just to see what kind of aspects there are. And what really struck me is that we have such a nice aspect within that model, which is called the mechanism of impact. And the mechanism of impact is something that is about the interactions of an individual with an intervention, but also the responses of an individual to an intervention. And I thought that might be, that could be key to finding out why an intervention works, or why somebody responds to an intervention or not. And what struck me within research is that there's really at the moment very little research on this aspect. So it might be really helpful to see if we can focus on that a little bit more. So this is just a little bit of background on my own thought process that really got me to focus on the aspects of engagement and personalization that we'll focus later on. So I'll get back to this model a little bit more later on. But first, let's see where I started, and maybe also where the field started a little bit a while ago. And it is about technology and adherence. So that's kind of a background also on my own scientific journey towards these questions of what works for which individual. And in my own PhD research, I really started with looking at adherence. What I found was that in a lot of cases, there was a very nice intervention with a lot of lessons and nice content and exercises. But what we saw is that a lot of participants didn't use all that content. Maybe they didn't start all the lessons, or they didn't use all the extra features that were there and that were added by the developers because they thought, oh, this will really, really enhance the effectiveness. So what really struck me there was that adherence or non-adherence, so using the intervention as intended by the developers, or non-adherence not using the intervention as intended, was such a big problem within digital healthcare in general, but also within digital mental health. And what we found in some of these earlier studies were that for participants who adhere, positive effects are greater. And this also kind of makes sense intuitively, because if people don't use the content that we as a therapist feel that is beneficial for them, how can an intervention be useful, and how can it be effective? So the question of adherence and trying to maybe also increase adherence to be able to increase effectiveness it is one that makes sense, and it's also what I did some of my studies on within the PhD research. And what we found, for example, in one of the larger reviews from a while ago, was that adherence was indeed an issue. In I think 83 studies we investigated in that review, we saw that on average only half of the people completed an intervention. But what was more interesting to me was that we were able to extract some of the features of the technology or of the intervention that could increase or that were linked to higher adherence. And these are shown on the slides, and maybe just I've ordered them in so the ones that have the most predictive value within the model that we created are on top. So more frequent updates was one of the most important things. So keeping an intervention fresh or new, to have something to really work with, that was one of the aspects that, or there was the aspect that was highest predictive for higher adherence. And there's other things in there that are interesting. So more extensive employment of dialogue support is one of the aspects from the human interaction, human-computer interaction side. So it's really about the technology or the interaction between the participant and the technology, and how much that is supported. And if we feel, or if a participant feels that it's more supported, that interaction, that was also predictive of adherence. And maybe just want to pick out the last one, the increased interaction with the counselor. I feel in my conversations with therapists, with people more on the work floor, this is kind of the thing that they feel is most important. So that's when you, if there is somebody who might not adhere enough, or you're afraid of losing them, then contact with a counselor or increased interaction is one of the most important aspects to increase that adherence. And in the review, we found that it is important. So more interaction with the counselor is related to higher adherence. But what I found really interesting was that it was less predictive of adherence than some of the other ones. So more frequent updates of the intervention itself, and also the more dialogue support was more predictive of adherence than increased interaction with the counselor. So that really got me thinking about, okay, what is that within an intervention? What does the technology also do within this context? And what I found, what I took out of this study, I think the main part was that technology matters. And I think in many cases, this is kind of a, yeah, of course, this is the case. But I think in many of the earlier web-based interventions, especially also for mental health, the technology was kind of seen as a given, as only the means to bring across the content of an intervention, but not really as something that had an impact. But I think this review, but also some other studies, really showed that the technology did matter in a sense. So persuasiveness, how much you feel a technology is convincing of content, of keeping using the intervention, that is important. The dialogue support part, so the interaction with the participants and the intervention itself, so the dialogue between those two is really important in there. And what we found in the review is that technology was important for adherence, but in some other studies we've also seen that the technology also can also be predictive or enhance the effectiveness of intervention itself. So until here, you kind of feel, okay, this is kind of a straightforward story. So there's technology, and we can influence adherence, and by influencing adherence, we're also increasing effectiveness. But unfortunately, it gets quite a lot more complicated. So what we've seen in some other studies, some later studies, is that technology is not always a predictor for adherence or for effectiveness. And adherence itself is not always a predictor for effectiveness. So the kind of starting points, we have to get people to use an intervention more or better, and then it will be more effective just by itself. And also, hey, we have a list of aspects of the technology that increase adherence, so we can just implement those, and then the interventions will be better. It's not that easy. We try to do some of that in a few of my studies, and we really didn't find these direct effects of technology on adherence or on effectiveness. And also there's lots of interventions that have shown, or lots of studies on interventions that have shown that it's not per se using an intervention more that leads to effectiveness. In some of these things, some of these studies, there's really no discernible relationship between how somebody uses an intervention and the effectiveness. So technology does seem to do something, but I kind of feel that it's still very much unclear what the technology does. And of course, that also makes it very difficult to really focus on how to design more effective technologies and more effective interventions. So that really got me thinking, okay,
I'm going to jump in with two clarifying questions related to just this particular topic, which is for dialogue support, what you were showing on the previous slide. Do you know if this is by humans or computer, like for example, a chatbot or both? And secondly, is dialogue support considered to be AI dialogue, app pop-up messages, texting back and forth with live therapists, or all of the above? So thank you.
Yeah, sure. Yes. So dialogue support is actually quite less complicated than that. It's much more about anything that can enhance the relationship between a user and a system. So there's things that what you can do with the technology is you can try and make it have maybe kind of a supportive personality by adding an avatar or anything. And that's already one of the aspects that might enhance dialogue support. But also adding a reminder, for example. That's also a very simple way of increasing the dialogue. So it's not an actual, it doesn't have to be an AI or an actual dialogue with a user and a system, but just anything that really can increase the way somebody interacts with the system. And if you want to know more about the dialogue support, is an aspect from the persuasive systems design model of Harry Oinas-Kukkonen. So there's lots of examples there in that field about how to increase the dialogue. But for now, it's really about the interaction in the sense of feeling maybe also a relationship between the system and the user, but not anything, doesn't have to be an actual dialogue. I hope that helps. Yeah, and then to go on, so how do we, so what do we know about technology? What can it do? And what we've seen in one of the earlier studies where I tried to figure out, okay, hey, we have this list of features that might be able to increase adherence and effectiveness. And in that study, we didn't find this this direct effects. But on the slide here, you see an example. So in one version, we try to increase the interactivity, which is also kind of an aspect of the dialogue support. What we did, for example, here is instead of just giving a text about living on automatic pilots, instead or trying to live with attention, what the assignment here was to click on the red button that's on the slides, and then you get a next picture and you click again and you click again and so on. So if you do that really on automatic pilots, then you won't see the funny things that are going on there. So in this particular picture, there's a bike somewhere on one of the large rocks. So if you just click without attention, you won't see those things. But if you do pay attention and you turn off the automatic pilots, and you see these kind of things. So in this way, we try to increase the interactivity and use more of the features of the technology in a sense. And so in this study, what we didn't find was that this version was more effective on average for people, or people adhered more to this version. But what we did see was that the involvement of people with the intervention was larger. And the same thing with adding text messages. We didn't see any direct effects on effectiveness or on adherence, but we did see that involvement increased with this intervention. And then I started looking into involvement. Of course, we added to the study as well, and it's really about a person's perceived relevance of the object based on inherent needs, values, and interests. It's really something from marketing science more. But what we found is that when we added this measure, this involvement, we found that it was very predictive for effectiveness. It was more predictive for effectiveness than adherence in itself. And technology seemed to influence this. So there might be something going on here. And in another study, we tried to also look into a little bit more. So what are the effects of changing a little bit of the technology? What does it do for the experience of users? And in this case, we tried to, we focused on the design a little bit more. So we created two versions of an intervention, which was the only difference was the design. So the one is more gamified and the other one is just text-based. And we asked students to just use this intervention for one session, just more in an experiment, and just measure what happens, is there any difference between the participants who used the more gamified version versus the one that was more just more text-based? So you measured all kinds of things in one session, and what we found here again was that the technology, so the more gamified version, really increased their involvement again, also measures of flow, and also some of the positive emotions, so inspiration and interest. So there were all kinds of things going on that might be related to later on to the effectiveness, but at least they're related to the interaction with the system. And when I got all of these things together, I found yeah, they're kind of getting to some part that or we might be able to bring them together. And I really thought about engagement and seeing that might be an aspect that is more that's more important in a sense for adherence or effectiveness. So just to recap what I've been talking about in these earlier slides. So what we found was that technology is not always a predictor for adherence or effectiveness, and adherence itself is not always a predictor for effectiveness. So what I was thinking is there a different for effectiveness? Is there something else that might be more important? And taking together the studies that I've talked about a little bit earlier, something about flow and involvement, maybe a little bit of positive effects. Is that engagement? Sounds about right. But when I really started looking at engagement, it was a concept that is used very, very differently in literature. It's always seen as important, but there was not so much clarity on what it was yet. But to me, it sounded like an interesting concept, at least to further look into. And what I really found, what I really was thinking, is that it might be one of the aspects that can be a mechanism of impact. So engagement seems to be about interaction with an intervention. It also seems to be about the response of an individual to an intervention. So we might be able to see engagement as part of this mechanism of impact. So it's just a bit of background on why I started thinking about this aspect a little bit more. But then my work really started shifting into engagements, and as already said, it's seen as important in many fields, and there's lots of literature about it. So I thought, okay, let's start by trying to figure out what engagement is, and if it's really something that has to do a little bit with flow or with positive emotions and things like that. So what I did was just do a systematic review on engagement in many, many different fields, and see what it is. And what we found, like the main aspects, was that it's seen as important in many fields: student engagement, work engagement, patient engagement, of course, user engagement. So there's a whole body of literature on engagement in all these different fields. And there are, in most of these fields, engagement is seen as consisting of three components. So there is something about behavior, there's something about cognition, and there's something about emotions and effects. And what exactly it is very different in each field. So that there are these three components is kind of similar, but what exactly these components are needs to be specified for each field. So I thought, okay, let's try and see if we can also do that in a different study. So what we did was just interviewing participants or people that were self-proclaimed engaged app users, health app users. And we just did very open interviews with them about why or what it is that that they were engaged with, or what it was to them to be engaged. And we really also found these behavioral, cognitive, and affective parts of engagements. And in behavior, it was much more on the routine of use than on the number of times you use something, for example. So people who were engaged really felt, okay, it's just part of my routine. It's part of the way I do, for example, physical activity and things like that. And the cognitive engagement part was also very strong, which was very individualized as well. So it was really about, to me, engagement means that I can use this app in this example to reach my goal. And this app helps me to motivate myself to reach my goal. It gives me insight into progress, but also into progress towards my goals. So that was really the personalized part there. And we also found a lot of comments or aspects about emotions, about affective engagements. And on the one hand, it was just the joy of using, so the enjoyment of using an app in this case. But what I found was really interesting was it was not just about that something is fun to use in itself. It was also really the enjoyment of seeing progress that you make. So again, also a little bit of connection to the more cognitive engagement parts, that they were seeing progress, that gave them joy as well. And what was lastly in this effective engagement part was that was really important that there was some kind of personal connection, so personal suitability from the person with the technology. What we found, and what I tried to visualize in the picture here on the left is that there were different engagement profiles for individuals. So for some, the behavioral part was really strong, but for others, there were much more about the affective part of engagement. And it didn't seem that any profile was better than another one. It was just different because there were different individuals. So it seems like there are also different engagement profiles for individuals. Which might have a different relationship to effectiveness later on for interventions. But at least what we found from this study was that we have this behavioral engagement, cognitive engagement, and effective engagement, and we have some idea of what that means for digital health interventions or digital mental health interventions. So what we did based on this study was, hey, let's create something to measure it with. Let's create a scale because there were a few scales on engagement, but the ones that we found were not really focused on really the three aspects, so not really on the behavioral, cognitive and affective part. But because we thought, okay, it is important to have a scale that measures all these three aspects, we kind of pragmatically created a scale that covers these three aspects. And if you want to know more about it, you can find the scale online, of course. But it has all these aspects that I talked about a little bit in the last slides. What we did with the scale is we tried to validate that as well, just to see what it does, if it's a useful scale to be used in studies to be able to measure this engagement part. And what we did is we asked students to use a step counter app for 2 weeks. We had a couple of measurement times. We measured engagement and also a different engagement scale. So the new engagement scale and a different one. Also some other aspects. What we try to do is also measure like the outcomes, the effectiveness of the intervention. That turned out to be quite difficult within such a short time frame, and also because we asked students to use any step counter app, so there was no fixed one, which made it a little bit difficult to see really have like an objective measure of effectiveness. So in this study, we settled for self-reported change as one of a more subjective measure of outcomes. But what we did in this study, we asked students to use an app to fill out the new scale a couple of times. And what we found, it was actually quite reliable, the scale. That was kind of unfortunate that we only found a single factor. So within this this study, in this scale at the moment, we don't have the three-factor structure that we would have liked to see with the three components of engagement. But at the moment, it's just a single factor scale. Correlations with related structures were all okay. And what I found was one of the most important things is that it did have a relation with self-reported change. And of course, this is still the subjective effectiveness outcome. But in my mind, if we want to measure engagement, or if we want to do something with engagement, then it really should be something that is related to outcomes, to effectiveness, but because that is kind of the mechanism of impact part that we like to measure. So I was pretty happy with at least one indication that the scale has also a relation with self-reported change. And so now we kind of know a little bit about engagement, what it might be. We have a way of measuring it. So now we might be able to get to the interesting parts. Could we also use this engagement to personalize interventions? And the way I think about that is, or at least the way I started to think about that, is shown here on this slide. The idea was that, or is that, you have different interventions, different treatments, and of course they are effective or not, so we have an outcome, but engagement might serve as a mediator. So what we feel is that different treatment options are often similar in effectiveness on average. So different content wise, or different design or feedback, or you can make a lot of different versions of an intervention, but on average, they're kind of similar in outcomes. But it might be that that is because people respond differently to those interventions. It might be that their engagement is also different, and that the engagement part is the one that's predictive for effectiveness, and that's the different treatment options engagement, and then in turn engagement influence effectiveness. So that was the starting point of my thoughts about this, and we tried to set up a study to see if this is the case. So what we did here is that we used 3x3x3 factorial experiments. So we created 27 versions of a 2-week well-being intervention. It was a mobile well-being intervention, and I'll show you a little bit more about all these versions that we created on the next slides. But what we did, we focused just on the general population, just also because we really thought that was more of a data collection study on whether or not engagement is a mediator. We measured outcomes on baseline, so well-being, depression, and anxiety, and we also did that after 2, 4, and 8 weeks, so after the intervention and some of the follow-up measures. And we also measured engagements. We did that with the new scale, with the tweets. We did that right after the first day of usage. So they opened the app once, went through one of the modules, and then filled out how engaged they were with the app. And they did that again after 3 days in the intervention, and after 7 days, so halfway. What I'll show here is later on some results of the 155 participants that completed baseline and the first outcome measure, so right after the intervention. And we have some more data, but I haven't gotten around to analyze that in a proper way. I would just give a little bit more background on how we created these different versions of the intervention. We changed, or we varied on content, so cognitive behavioral therapy versus meaning versus positive psychology intervention. So we just used the things that you find out there. So they're all based on other larger interventions, and we picked out some of the important psychoeducation and some of the interesting exercises to really try to create 3 different versions of an intervention that also might appeal to different people. So we weren't trying to make one best intervention, but just have a few options. And we did the same for the design. One pretty basic with like a calendar. Hey, this is day 1, and you go to day 2, and so on. And we also had 2 more gamified designs. One where you get more bricks each day, so it's more competitive, you get a higher number of something, and one which was more of a storyline gamification. There you follow your avatar on a bike ride, and he explores a new area every day. And the last thing we varied on was on feedback. So we had like the feedback content was always the same, based on the exercise that participants did. We had the basic one just with text, and then we had one with text and an avatar. And lastly, we had one where the text was spoken aloud by in video by a counselor. And what we found was, first of all, that the intervention itself seemed to be effective. So after 2 weeks, well-being, which you see in this slide, was higher. Depression, anxiety was lower. No significant difference between the levels of the factors times time. So we didn't find any differences. There was no one version of the intervention that was better on average than the other ones. And what I found was really interesting was that engagement was a significant predictor for outcomes, mainly at points 2 and 3. So at time point 1, after the first day, it was a little bit tricky. For some of them, it was a little bit predictive, but for some, it wasn't. So for that time points 2 and 3, so after 3 days and halfway through the intervention, it was really a significant predictor for outcomes. But what we saw was that there were no significant differences also between the level of the factors, so between content and engagement. So the CBT intervention was on average, for example, not more engaging than the meeting intervention, or the way around. So engagement wasn't a mediator, which kind of makes a lot of sense when you think about it. So what we concluded from this study was that yes, some of the hypotheses are confirmed. So the different interventions perform equally on average. Engagement is related to effectiveness, which was kind of a positive, I think, from this study. What we didn't find was that engagement served as a mediator. And as I said, that makes sense, because kind of the same thing seems to be happening, the different content variations, for example, might on average not be more engaging than another version, but for an individual it might be. So that's kind of the conceptual difference that we need to make, I think. Engagement might be, in a sense, an individual mediator, but it's not something that we could find from this study. But the question was still, can we still use engagement to personalize interventions? And I think we still might be able to do that, just because it's we did find, it is very possible that individuals respond or engage differently with different interventions. And to really see if that's the case, and if that's also something that we can use in a different study, we set up a pilot study for personalization. And it was just pilot testing a procedure for personalization based on engagement. And what we did was letting participants preview the different features of the intervention. We did that quite simply and pragmatic within an online survey tool. What they could do is preview and compare the different content options, the different design options, and the feedback options. And each version of the feature, they scored on the tweets. So they scored on engagement measure. So what we have after they scored all that, we have kind of a basic idea of how engaging each of the options is of each feature. And this is the data that we think that we can use to personalize an intervention. And what we did to test this assumption is that we sent participants a second survey a week later. And that survey, again, contains previews of the intervention, but this time not from the separate features, but a specific combination of features. So we had the optimal one, that would be the one that they would get when we would use their engagement data to really personalize an intervention. And we did some other combinations, so a second best, a medium fit, and a least fit. And what we hoped was that the optimal intervention would score a bit better than some of the others. But we were quite surprised that the optimal version really scored significantly higher than all of the other versions. So even the second best, which was only different on the design, and it had the same content and feedback as the optimal intervention, but still engagement after 1 week was significantly higher with the optimal intervention than the second best. So these results at least indicate that we might be able to use like a procedure to get a most engaging version from an intervention based on their scores on the preview. This is of course interesting, but I don't think it's enough. I think that the real test is going to come, and so we need to really try to answer the real question: does it really work? Can we use engagement to personalize a digital mental health intervention? And of course, is this personalized intervention then also more effective than non-personalized intervention? And this is a study that's currently running. So we have about 200 participants that have, I think, already completed the post-intervention questionnaire. We used the procedure from the previous study to personalize interventions. For half of the participants, we actually gave them that personalized, that optimal intervention, and the other half we gave one of the random, one intervention of the random 27 ones. We measure well-being, depression, anxiety, of course, also engagement a couple of times. So now really there is the test to see if this is the people who are randomized to their personalized intervention outperform or are more effective than the people who are in the non-personalized intervention. Unfortunately, I can't tell you the results yet because they're not in, but I'm really curious to see if this really is the case. And if so, then I hope that we can kind of make this circle a little bit more full. So we have this mental health care crisis and the possible solution of digital mental health interventions. And with engagement, we might be able to see, have that mechanism of impact and to really have something to intervene on and to be able to personalize an intervention and also create more effective interventions for all of for everybody. So to pick the right one for everybody. And I really hope that this is a way that we can go forward to understand a little bit more about why interventions work and to be able to create more effective ones. So that brings me to the last slides. So thanks everyone for listening, and I'm very happy to answer any questions that you might have.
Thank you, that was amazing. We do have several questions, and I'm also wrapping my head around how awesome this hall has been. And you have some nice comments in the chat too, just really praising sort of spending time on the role of personalization. It's really exciting. So thank you, this is awesome. I will start with some of the low-hanging fruit questions. So the first one was that, can you share the reference for the large review on adherence showing that average adherence was 50%?
Yes, of course, I can send it. Yeah.
Actually, Saskia, is that the persuasive systems design paper?
Yeah, that's the one. Yeah.
I'll pop that in the chat.
Oh, thanks. Yeah, that's actually one of the conclusions from that one was already a while ago. But that was that praise wasn't used enough in many of these mental health interventions. And I think that was my first contact with David, actually, because he sent me an email after that paper saying, hey, praise is not something that's not only used not often enough in intervention, but also in the research community as a whole. So he had a very nice message about that. So thanks again, David, for that.
And look, it has a big impact. We remember it long term.
Yeah.
You actually started to, in some ways, touch on this a little bit later in the talk, but we had a question from Trina saying, do you see different patterns of use comparing CBT and other clinical techniques?
Ooh. Oh, that's a difficult one. Yeah, I haven't actually looked into that, but what we found already when we tried to create the different versions of the intervention, so CBT versus some of the positive psychology versus some of the meaning intervention, is that you ask a lot of different things from participants when you do CBT versus some of the others. So actually we were ending up adding some more modules, some more actions per day within the CBT interventions versus more of the positive psychology. So I think we do ask a lot of different things, and we do kind of ask people to use it in a different way. I'm not sure if we actually always implement that in the system, and I'm not sure if that's actually something that we find out of, that we can see in the data, but I do think we ask different things of people.
Thank you. And you similarly actually started to get at this too, which was really neat in some of your more recent pilot trials of this. But Dennis Lee asked a question of how might engagement and the measurement of it differ for eHealth interventions that could be less routine? So a one-time educational program versus something you're doing longer term.
Yeah, so I think so for my research and also for the scale, I really focused on interventions that you have to use for a longer time, and that's the routine really comes in more. And I think, of course, in many of the things, it will differ a little bit. So I think that routine part is especially one that it would change. That would be a little bit of different content. So even maybe the whole behavioral part, but it might be less the routine of using an intervention and more about seeing that using the system as part of the larger behavior that it's related to just having it being part of the larger behavior. If that makes sense.
Thank you. Do you think personalization or engagement of interventions would be efficacious in an EMA study, design study, so designing ecological momentary assessment?
Oh yeah, I think it's also something that you could really use for that. And what's difficult with engagement is at the moment we only have like scales that measure like overall engagement for a while. And I think, especially if you want to go to EMA, you need to have like the engagement parts that are more momentary as well, so that are much more fine-grained. And I think we're really not there yet. And of course, you don't always have to be highly momentary engaged maybe to still have use for a system. So I think it is important, and it can be very important, but we need to know a little bit more about how engagement goes over time, how to measure it in more fine grains to be able to really use that in those settings as well.
And I think that's where, with personalization, some of the computerized adaptive testing that people are doing and the way in which questions get varied based on how people respond, it sort of gets at some of that too. And not necessarily the engagement piece, but also the precision. And I think that's core. It's trying to think about sort of how people are giving them less questions to answer as an opportunity to sustain engagement over time.
Yes.
Someone had a great question, which is it possible to get a copy of the slide deck? So the talk is recorded and will be posted on our center's YouTube channel and available through our center website in a day or two. So you can always review the slides through that. So the question is, thank you for a great presentation. As you mentioned, the same interventions are used differently by users. Do you have any input about the individual characteristics that may influence engagement with an intervention? Yeah,
and I think this is one of the key questions. And in my research, I haven't found those yet. And if they are there, then kind of we might not need engagement as a concept. So if we know this for this person, this kind of intervention works best, for example, then we might be able to just skip engagement overall and just say, hey, for these people, we need to do this and this and this. But from my research, the only kind of constant thing I found was that when an intervention fits a person, then adherence, engagement, effectiveness is higher, but kind of that fits that might exist on various levels. It might be a very text heavy intervention, might fit a user that's more cognitive able or more focused on kind of these knowledge things. But we might have so many different characteristics that we might be able to use to assess whether or not there's a fit. That's kind of the issue why I thought, okay, maybe we'll try engagement and we'll just do it experimentally and have people experience different versions to see whether there's a fit, instead of trying to figure out which of the characteristics that we need to take into account.
Relatedly, I'm going to jump in your the pilot trial that you're doing now, sort of study number 6. When you, or maybe it was study 5, when you gave people the optimized intervention, was that for them or across all of the users?
For them.
Wow.
Especially for them.
Yeah. So it was truly tailored for them, what they ranked most highly to themselves. That's amazing. And that's what you're now systematically testing.
Yeah, but in this case, I mean, we did it really pragmatically. So there's no AI or nothing in there. We just had people rank kind of these things on engagement, and well, in this case we just have a student who manually goes through that data and assesses that. So just to see if this is something that works, and if it works, then we can go into a little bit more depth and see if it really if we can automate it a little bit more, for example. But for now it's just basically having somebody tailor that for them.
Can I just follow up on this, because I found that just fascinating, and so you only found that the optimal engagement was really effective. So are you interpreting that as, people are very unforgiving of things that they don't, if there's one thing wrong, then it's out, and so is that kind of the way that you interpret it, or?
Yeah, I'm not so sure. Yeah. I thought, okay, content will find an optimized version and that matters. But I thought for the design and the feedback, I think it might have some influence, but not that much. But it had quite a lot of influence. So I'm really not sure how to interpret it. It can be that's so unforgiving. It might also have something to do with we're showing them everything. So it might also be something as I kind of chose that, and now you're giving me something else. So I really
Maybe,
want to go into the choice aspect a little bit.
Were these students or general population? Because I mean, I don't have data for this, but my impression is that younger people are much more critical users of technology than older people.
Yeah, in a sense. So one of the outcomes of that pilot study was also that they felt they had a lot of input. They answered questions a lot of times, and I thought, but now you're giving me only one personalized intervention. You could have done more for what I gave to you, with kind of question. So they are quite strict on what they expect from these things. Yeah.
We similarly have comments, coming through as well. So we have time for, I think, just a few more, so I'll sneak them in. So Sue Shankman says, really interesting talk. In examining the role of engagement on effectiveness, do you think that by not using a clinical or even a treatment seeking sample may reduce the variance in effectiveness, as folks may not have a lot of symptoms or improvement to actually improve upon?
Yeah, so in this case, I really, because it's all kind of still theoretical work, we really focused on the groups that didn't have that much complaints. What we did in some of the studies is, for example, we excluded people who were flourishing, so who were who had too much well-being already, to make sure that we can see some improvements. So I feel that it is it touches upon something that is, I think, more generalizable also to other populations, and also just from so one of the larger mental health care platforms also has integrated the engagement measure, and they're also performing their own analysis on whether or not engagement is predictive for effectiveness, and they're finding the same things. So those are with more the clinical populations.
So this is a commercial company doing that, you said? Yeah, and so how often are they administering that?
So at the moment, we've asked them to, or they came to us for advice. So we asked them to do that after the first day again, and also after a couple of weeks. And I think they mainly, the larger relationships, or the stronger relationships, are the longer within the intervention. And the beginning is kind of tricky. There is some relationship, but it's not always very strong. So we're also really looking into, okay, should we have like an initial version, or should we just add a couple of days to see, hey, if there's a drop, then there's, okay, there you have to worry, but if it remains steady, it's a lot better. So to have a little bit more data to play around with.
Yeah. Cool. I see we're admittedly at time. This was amazing. The last sort of quick question, one was whether the interventions are primarily cognitive or clinical. This person missed a little bit of the beginning, so clinically oriented. But the last question is, could you comment on how engagement measured by the TWEET scale overlaps with or is distinct from preference, like for a certain intervention condition?
And I think that's a great question. And at the moment, my answer is I don't really know. It feels that it is similar. What the students in our pilot study said, that it helped them create their preference, or to find their preference. So I think it is somewhat different, but it's also related. And if in the end we can just ask, hey, which one do you like? And we can just have the one question, then I'm all for it. And then we can kind of, for these kind of things, not worry that much about engagement. I do feel that there is a difference, but I'm not sure yet. And we really need to do a lot more work on that to see what it is that is different.
An inspiring closing message.
Great.
All right. Well, we're right at the top of the hour. So Saskia, I really, this was a great talk. Thank you so much for taking the time out, and all of the comments. I don't know if you've been tracking it, but all the comments in the chat. I mean, it seems people really enjoyed your talk. So for those of you still remaining, I just want to mention that next month we will be having an overview of the research that's going on in CBITs. So please join us next month, first Tuesday, noon Central. And Saskia, thank you so much.